Greetings and welcome to another lecture in psychopathology. We'll be finishing up the schizophrenia chapter here, talking about various types of treatments. Now, the first type of treatments are going to be the pharmacological. They're going to be the drug, the medication treatments. These were the first to really find success. A large proportion of people in institutions prior to the 1950s had schizophrenia because there was nothing really that could be done to help them. With the medications that we have now, there are ways in which people can at least have their symptoms reduced, which is not a cure, but it's better than doing nothing. So, just as a reminder to my students, you don't really need to know the brand names here. You may want to know the drug names themselves. The brand names are in parentheses to just have an idea. Mostly they're there so that if you've heard of these, now you know what they're used for and perhaps a little more about how they work. The first generation antipsychotics, not to put too fine a point on it, changed psychology forever. They were able to help people that simply could not be helped before, that had been destined to spend the rest of their lives in a hospital. And now a lot of these people, not all, but a lot of these people could wind up living relatively normal lives because of these medications. They include chlorpromazine, which is also known as thorazine, and haloperidol, which is Haldol. Now, what both of these are is they are dopamine antagonists. As I mentioned at various times in the possible causes videos, it really does look like that schizophrenia is linked in some way with dopamine. And what do these drugs do? They reduce the level or the effect of dopamine. And they work best for positive symptoms, which brings us back sort of to that whole positive symptoms may be due to excess dopamine or not enough glutamate, and then negative symptoms may be due to brain injury sort of deal, because it does look like the dopamine antagonists work best for positive symptoms. Now, these drugs do have some fairly wicked side effects. They're not good, these side effects. They're better than schizophrenia, but not by a whole lot. They include drowsiness, dry mouth, weight gain. Those are not a huge problem necessarily. They also include what are called extrapyramidal side effects. And these side effects are also called Parkinsonian side effects because they consist of tremors. Parkinson's disease, which is caused by something entirely different, although it does involve dopamine, I'll tell you that, is basically just tremors, rhythmic tremors in the extremities and then moving on to the head and that sort of thing. It can also cause tardive dyskinesia. Tardive dyskinesia is involuntary movements, large involuntary movements, not just tremoring. Large involuntary movements, often of the face or mouth. So these movements could be somebody opening their mouth or sticking their tongue out or widening their eyes or scrunching their face. Or it tends to be very large. It's almost like a tic, but it's a lot bigger than a tic. It's a very, very large tic. And it is something that is not controllable. That's the deal about tardive dyskinesia. It's not controllable. People can't stop it. They can't keep it from happening. They can't do that with the extrapyramidal side effects either. The other nasty thing about these side effects is that often, if these side effects are allowed to get well established, they don't go away when you stop taking the drug. Normally, side effects go away when a person stops taking the drug, but these can become well enough entrenched to stick around. You really don't want to screw with the brain's biochemistry if you don't have to, particularly something like dopamine that's involved in so many things, particularly movement. So in the olden days, when the first generation psychotics were the only ones that were available, people didn't have a whole lot of choice. They could either, if tardive dyskinesia showed up, they could either go off the antipsychotics and therefore wind up with their schizophrenia symptoms generally coming back, or they could deal with the tardive dyskinesia. And most of them wound up deciding to go with the tardive dyskinesia. It's unpleasant, but it's better than schizophrenia. Nowadays, there are other drugs that people can be switched to. And in fact, when someone is taking a drug that might affect their body in such a way to cause this tardive dyskinesia, if you watch TV, occasionally you'll hear commercials for drugs where they talk about involuntary movements of the face and call your doctor. You need to do that, because it's possible that if these movements have not been allowed to become entrenched, that they may go away if the person is taken off that particular medication. And that would be a very good thing. So nowadays, what will happen is if those symptoms start to show up, the doctor will take them off the medication that they're on and switch them to something else, maybe one of the second generation antipsychotics. These include things like clozapine, which is also known for clozaril, risperidone, which is Risperdal, quetiapine, which is Seroquel. All of these also essentially help deal with the symptoms of schizophrenia. I suspect they all have a tendency to work on dopamine or something similar, but they tend to have fewer side effects, at least in terms of the extrapyramidal symptoms, and I think also with the tardive dyskinesia. So they're a little less likely to cause these, and it does indeed give doctors then a chance to switch a patient who's having problems with other medication to these. They also have the same kind of side effects. Drowsiness is true for both. Sometimes, in fact, these antipsychotics are lumped in with depressants, are lumped in with tranquilizers. Because in a way, the ones particularly that work on positive symptoms are just kind of a weird kind of tranquilizer. They reduce the amount of movement and that sort of thing. Extreme weight gain as well as diabetes are also a problem. Whether diabetes is directly caused by the second-generation antipsychotics or whether it's simply a function of extreme weight gain, we're not sure. Something else, by the way, that may also help with symptoms of schizophrenia and may explain why men are more likely to not only get schizophrenia earlier, but to get it worse. Estrogen can help symptoms of schizophrenia. Don't know why. But that might well explain why women, for instance, may not start showing signs of schizophrenia until the levels of estrogen start to decline in their 30s and 40s when they're in perimenopause. So maybe that's when the symptoms might start to show up. And why men might get it much earlier because men have much lower levels of estrogen than women do. But it is possible for women, for instance, you don't really want to treat men with estrogen to treat schizophrenia because estrogen has so many other side effects that it's really not a good thing for men anyway. It has feminizing characteristics and can really change a man's body quite a bit. But estrogen has been used in women, particularly in menopausal and postmenopausal women to treat schizophrenia, and it seems to work pretty well. So it's something else to try. Psychosocial approaches. Well, these work, but they don't generally work as well as the biological ones do. They're probably best used in conjunction with the biological treatments, in the same way that antidepressants should often be used along with therapy to help someone with depression, instead of just relying on the medication to pull the whole load. For instance, family therapy. If they can reduce that expressed emotion, particularly the negative expressed emotions, the saying the nasty things afterwards, that's good. That can help the person not relapse again, should they, in fact, go into, a remission of schizophrenia. Case management can be used to help people when they've first been released from hospitals. Case management helps patients, help people with schizophrenia to find services that might help them. To help them, for instance, find halfway houses, to help them find places that will allow them to work, with supervision, that sort of thing, in order to just get them out of the hospital where they may not need to be, to give them that little bit of care that they need in order to live fairly independent lives. Social skills training can also help. Remember, people with schizophrenia very often have problems telling emotion and that sort of thing. So this might help them get better social skills, to help them be able to relate better to others, to keep friends and family and that sort of thing, which can also help them live a relatively normal life. There are skills that can be taught to try to overcome those neurocognitive deficits, the problems with memory and attention and, self-discipline and that sort of thing. It is possible to teach people skills in order to be able to overcome that. Cognitive therapy may indeed help. Cognitive behavior therapy might help. It might help, for instance, it has been shown, at least in some, to decrease the intensity of positive symptoms. If someone is having a delusion or a hallucination, it may help for them to be able to more or less argue themselves out of it. To tell themselves, well, this isn't real, it can't be real, therefore it's not real, and maybe be able to move on. It helps to reduce relapse of people back into full-blown schizophrenia from a more recovered state, and it also decreases social disability in possibly the same way that social skills training does. It helps them be able to deal better with others and therefore lead better lives. Individual treatment is sometimes, well, all of these could be individual treatments, although some, like family therapy, will be group. But quite frankly, educating the patient as well as their family about the illness and the treatment. Schizophrenia is one of those things we don't know a lot about. I mean, you hear people sneer about someone's gone schizo or what, but people don't necessarily know about it, know what it is, know what makes it up. And it can really help to educate not only the patient as to what they're going through, but also the patient's family and friends and workers and employers, and it may help to let people know exactly what it is the person is going through. This may help the patient feel less frustrated. It may also help the others in the patient's lives maybe know how to help, know what they should do, know what they shouldn't do, know what they should expect to see. And that can really help someone succeed and live a hopefully relatively normal life, even with schizophrenia.